Thank you. My first comment is going to be on nursing thrombolysis. I can get feedback from my own phone, so it's causing a bit of a problem. The evidence base for thrombolysis, as we all know, started long back in 1995, when the first favourable outcome of a research showed that it was worthwhile doing it. It has been further analysed, and extended windows came through. The action for thrombolysis is that it's a thrombus that's formed, so that's what it's sort of about. The alteplase binds with the hydrogen in the thrombus, converting it into plasma protein and initiating the thrombus, which is why it's called the clot buster. Doesn't really bust the clot, but it washes over it. 50% of it is actually cleared within 5 minutes after the infusion, and 80% is cleared within 10 minutes. And you can see the diminishing returns that came through the results. So the faster you give it, the actual benefit there is. By you getting to 4 hours, you can see there's minimal advantage. And by 6 hours, you're starting to get as many complications as you would do good benefit. And you can see, if you look in the first 90 minutes, that's where you get your most, but that's from onset of symptoms. So you're really trying to give the needle and the drug before the 90 minutes. I know we have 3 hours or 4.5 hours, but the closer you can get to that 90 minutes, the better. So what do we have to do when you think about it? In that 90 minutes is a lot of work has to happen. The patient has to be aware that they are having a stroke. And the only way you can do that is by public awareness. So it's getting the people to recognise the symptoms, which is why we've all come with the FAST, and it's been adopted worldwide. Everybody knows FAST, yes? Face, arm, speech, time to treat. Others have started to bring out the BFAST, which includes ballads and eyes. That is really good, but it opens the door to a lot of false strokes as well. What you're looking for thrombolysis at the easiest is the barn door obvious, the strokes that look like strokes the moment you see them, and they're the ones you want to treat very fast. We need to know an onset time, or last seen well, or were they a wake-up stroke? Next. The ambulance service are the ones that pick it up. It's much easier because the system is set up for ambulances. If a person comes in on their own transport, it means that they then go through a triage system in the ED, which means that your ED department has to be trained to recognise the FAST. If they come in via ambulance, you're cutting time because the ambulance service are trained to recognise it, to check they've got positive symptoms for a stroke. They can check the blood monitor so that they can see that it's not a hypoglycemia causing the same sort of symptoms. They can confirm with the relatives or people on site what time it started, and they can bring a relative with them, hopefully. You can also bring medication with them, because even if the patient doesn't know what medication or can't communicate to us, if they bring the medication with them, we can see if they're on warfarin or on a factor 10 inhibitor. And you can get a pre-alert to the A&E department. And that means that the whole system is then geared up much, much faster. The prior to admission warning allows that the imaging department can be told, so that the ambulance coming in rings the AED department. The ED nurse taking that call is then responsible for pre-alerting the stroke team and also pre-alerting the CT scanner. Because if the CT scanner has a patient in, they can finish that patient and move it, and they don't accept another one whilst we're getting this CT scan, this patient in. A brief medical history needs to be taken and just confirm the onset time, the inclusion, the exclusion type. And I say brief medical history. You do not want to be delaying time of this patient getting into the CT scan. You say about performing an NIHSS. It's great. You don't need to do the whole lot. That takes time. You can do it quickly. Eyeball the patient. Has he got right-sided weakness? Has he got any movement? If his arm is dense and his leg is dense, he's already scoring an 8, which puts him in the category. You don't have to worry about everything else. If it's only looking at it, if it's really, really high. So you want to do that to get them into the CT scanner. Once they've done the CT scanner, you can look at them, estimate the weight. If you've got a bed with a weight machine, great, but don't again waste time getting them out onto scales. Blood pressure. Forgotten quite often, very first off, because you're in such a rush to get to the CT scanner, but it needs to be checked initially to see that they manage it. Because if it is over that amount, you want to be treating the patient first. Again, IV access. It's better to get 2. So you've got one for the thrombolysis and you've got one for normal fluids. However, if you've only got one access, don't delay the thrombolysis. You can get another access later. You can take urgent bloods, but you should not wait for these results. If they are on warfarin, you need to get the INR, and that should be done by point of care testing. ECG and chest X-ray, down the line, way down the line. And consent. Now, consent is a tricky issue for many countries. Here in England, we don't need written consent. We treat, and we just talk to the relatives if they're there and the patient if there. Over in Qatar and in your own countries, written consent is often needed. So if the patient isn't able to consent themselves, then you need a next of kin. And the nurse's job should be that they're already telling the relatives what's going on. If you're keeping them up to date and talking to them, and you're telling them that the doctor is doing a CT scan, if the CT scan comes back and is good, there is a drug we could give. You're not taking consent to give that drug, but you're talking the family through it, so that when the doctor comes out and says, right, we have a drug, we can treat this, your relative is suitable, it cuts down the time and takes to get that consent. The absolute contraindications. There's 3 main ones, and you will see in lots of paper there's lots more. But you look at the 3 main ones. They are intracranial hemorrhage. Obviously, if they're a bleed, you're not going to give something that's going to make them bleed. They have active internal bleeding. You're not going to give them something that's going to make them bleed again. And there's endocarditis and acute pericarditis. You would not do that. So those are the 3 absolutes. Oops, Sorry. But you stop and you think a lot of other things. So your INR greater than 1.7, you would not give routinely. You would think about it because the risk of bleeding is greater over 1.7. Glucose less than 2.7 or greater than 22.2. Are you sure this isn't hypoglycemia? Are you sure it's not a problem with their diabetes? If the glucose is corrected, then you can look again. BP greater than 185 over 110 after 2 attempts of reducing the blood pressure. So you would, if you had that blood pressure or higher, you would treat and treat again within another 10 minutes. If it's still raised, you would be very reluctant to do it because at that level, you're likely to get bleeds. Surgery in the last 14 days. Now, it's always used to be an absolute contraindication, but it depends what the surgery is. We treated a patient who had a total knee replacement, and they were literally just out of theatres. And it was discussed with him, and it was discussed with the family and the consultant who did the operation. And it was tightly bandaged, and they treated. Seizure on the onset of stroke. Often it used to be thought that when you had a seizure, you looked twice for the tumour. But strokes can come with a seizure. So if you're confident that there is no tumour on that CT scan, then you can treat. And serious underlying medical illness. So if you have cancer or something else that's going on and your palliative care, are you going to treat it? It's conversations that need to be had. So the art of TPA decision making. You look at it and you think, okay, they are young. It's early onset, so they've got into the hospital very quickly. The glucose is okay. The blood pressure is okay. Everything fits in protocol. And they're moderate to severe strokes. The middle line, the NIHS 5 to 20. And the CT scan is good. Then treat enthusiastically, you go for it. You would treat cautiously if they're late. So they're getting onto the 4 hours. Their patient is elderly. Their blood pressure is high or really borderline high. And their blood sugars are out of range. If they're off protocol, so there's something going on, they either had an operation or things aren't quite right. If it's a very minor stroke, is the risk of giving the drug greater than the damage the stroke has done? And this is where a lot of people have a problem, because they quite often do not treat minor strokes and then 3 days later wish they had, because the minor stroke actually is quite debilitating. The CT scan is bad in the fact that there's a lot of white matter disease, there's a lot of shrinkage, the elderly, or the NIS is high, over the 22. And then you would treat cautiously if you were going to treat. Going back, there is always, if you want to treat, there's always a push to, but if you don't want to treat, you can always find an excuse not to give. So you have to be confident, and the consultant and the doctors that are dealing with it have to be confident in making that decision. So access, as we said, 2. Use one for the TPA and one as an IV drugs. And you need to think about the potential side effects, patient education, proposal for therapy and gaining consent by the family. And as I said before, that should be down to the family, to the nurse to talk to the family. Prior to infusion, the blood pressure should be managed. And the treatment that we used is the labetalol. 10 to 20 push over 1 to 2 minutes. And repeat 10 to 20 minutes. So you can repeat it up to a maximum of 300 milligrams. Okay. If not, use beta blockers. Do not use beta blockers if their heart rate is lower than 60. Then you'd use a hydrazine and to bring it down. Okay, you need to check that. And preparing the vial. So you look at the vials, you've all seen them, I'm sure. The 2 glass bottles, and they come with one with powder in and one with the it. Do not shake the vials. When you're trying to do this, and you're trying to do it quickly, and they're all going, quick, 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 we've got to get the needle, and you shake the vial to get the water, the solution to dissolve, it actually takes longer to then draw it up. And also you're destroying the protein strands. So swirl it, and it will dissolve, I promise you. You're looking at how much to give. And what you've got to do is determine the weight of the patient. And then it is 0.9 milligrams per kilogram of weight. And the important factor is it's up to 90 milligrams, which is 100 kg. Over 100 kg, you do not keep going up. You stop at the 90 milligrams. So if it's 120, you're still giving 90. Yeah. Sometimes people forget and they're calculating it. And then you withdraw 10% as a bolus, and you give over 30 to 60 seconds. And then you set the reconstitution and prime the line. Set the infusion pump up and give it over an hour. So that's the total amount minus the 10% over an hour. The trick is, and this is very important for the nurses, because the doctor is concerned about getting that first needle in, because everything is about door to needle time. Then where they're left, and we're the ones that put the infusion pump up. But it's no point if the infusion point is in the ED bay, the patient is in the CT scanner, and then they're going to have a CTA or something else, and the infusion is not started for 25 to 30 minutes. It's a waste. You're not giving the patient the best chance. Once that needle goes in, you should be starting that infusion within 3 minutes. So whilst they're doing the bolus, you should be preparing the rest of it to do and start it straight away, even if it's in the CT scanner.
So as you can see, we should be doing, after the thrombolysis has started, the needle and the infusion is up. So the doctors back off, the nurses take over. And this is where you should be assessing the observations. You're so important in keeping that blood pressure controlled. If that blood pressure is allowed to increase and go over 180, the chances are that patient can deteriorate and have a bleed. So the nursing and aftercare of that needle going in is the biggest part of it all. So you should be doing the blood pressure, and you should be doing it manually, and you should be doing it every 15 minutes for 2 hours, and you not just taking it and recording it, but if it's starting to creep up, you start letting the doctor know. Don't wait until it is over 180 to get them involved. And then at 2 hours, you should be assessing their NIHSS. This is so that you can actually see whether things are going well or not. If there is any evidence of deterioration. So the nursing, what you should be doing during it, is you avoid taking the blood pressure in the arm with the IVs, and you try and avoid doing venipunctures. You avoid unnecessarily handling. Don't forget this infusion is going through in an hour. Patients can wait to be undressed. They can wait for the toilet the vast majority of the time. There is no rush to get them here, get them onto a ward. You just get them stable. People tend to get very excited about thrombolysis, especially if it's fairly new, and then they're sort of rushing the patient here, and they want to get the patient on the ward, and they want to get them, and all you're doing for that patient is increasing the blood pressure. Take people away, calm the situation down, just you and the patient, settle it down, and you'll find that the blood pressure is much easier to manage. Avoid taking blood. There's no reason to take a blood straight away, so just wait and take it. The same with catheterization. Don't do it beforehand. You're wasting time. Most people can wait at least 2, 3, 4 hours. I know we say don't catheterize within the first 24 hours. If a patient is in retention, they will manage at least 6 hours. And don't forget, the infusion is already out of the system very quickly. So the longer you leave it, the less chance there is that you get a doctor to do the catheterization if needed. Apply dressings to potential sources. These are patients who come in and may have fallen, and you may have a cut across the head, so you need to make sure that it's pressed. They may have banged their arm, they may have cut themselves as they've fallen. And assess all excretions for blood. So make sure that if they do pass urine, that there's no blood in it, that they do have the bowels open, there's no blood in it. Because the possible complications, and it's less patients are young. Over here, our average age of a patient having thrombolysis is about 77 years old, and they go on up to 100, 104, I think the eldest one that's been done. So you think that we have higher complication rates because they're elderly. You have a very young population for stroke. So the chances of intracranial hemorrhage are lower than the 6%. Your major systemic bleeds are 5%, and that's worldwide, and the angioedema is 2%. So if you've got symptomatic intracranial hemorrhage, you think somebody's done, you organise a CT scan, but the very first thing you do is stop the infusion and tell the doctor. Yeah? There is no evidence of any benefit of trying to reverse it. And that's been given, they've often tried to do the vitamin Ks or anything else, and it doesn't work. It's not making, if they've bled, they've bled. Major systemic hemorrhages, GI bleeds and urinary tract are the most common. But if the patient, you can treat them afterwards if you can do it with infusion or surgery, but you should always investigate, because it's been found that people who have GI bleeds often have early stage cancers that you're not seeing or not being picked up previously. So it might be that the thrombolysis is actually doing them a favour as well, in the fact that you're actually finding their cancer at an early stage. Angioedema is where your tongue swells. It's a very rare complication. And again, there is no specific treatment for it. So it's recommended the same as anaphylactic shock. So you would give the cortisones, the antihistamines, and if it really, the tongue gets so swollen that they can't breathe, then you may have to intubate. If you have to intubate, I can guarantee most of them don't do well. So you try and manage it much easier. Sometimes it's just mild swelling that you will see. Nursing care. Remember, the needle is the starting point. It's what you do after that needle goes that will make a big difference to the patient's care and their outcome. Just as the last thing, tenecteplase is coming. It's there. As far as I am aware, and I'm sure the Angels team will be able to correct me on this if I'm wrong, is that it is not FDA approved as yet for stroke. It is FDA approved for acute MIs, but it may be a game changer because it will only be an injection. You won't have to do the infusion over that time, so things may be quicker. It's cheaper. It has a longer life, so it can all be given in a bolus. So it might be more feasible for medium-sized hospitals to give this, which means that more stroke patients will be able to get this treatment. That is the end of that.